afternoon, everybody. Dr. Danthuluri here. Just following up with you after our last talk about how it can be frustrating to gain weight and an inability to lose weight due to that key evolutionary mechanism called metabolic adaptation. I promised you we'd be talking about the different surgical options and then try to understand how they work and how they intervene in that metabolic adaptation mechanism to get you the results that you so desire. So with that, let's get started. Let's start by talking about normal function in the human body. So in terms of how we eat, digest, process food, there's a couple of key things that happen that I think are important to understand, at least the way that I describe the surgeries. And I'm going to go ahead and point out a couple of things here. Number one is something called the mixing point, indicated here with a star as well as here on the anatomy picture. And then I want you to remember this key number, 16 to 20 feet. That's how much intestinal length we have to process the food down to its building blocks, those core calories, the lipids, carbohydrates, and proteins. We have a tremendous surface area built into our intestine to absorb every last drop of that. Remember, going back to when we were more primitive, we couldn't afford to miss a single calorie out of what we were eating because we weren't sure when we would come across food again. So realize that this whole system is built to be extremely redundant and extremely efficient at getting calories out. It doesn't care that over the years we figured out how to line our shelves with calories, remember, like I said. It's just doing what it evolved to do. After we understand how normal function works, you'll be able to better follow me as I describe how the surgeries impart different changes to this anatomy to get the results that we want. Broadly speaking, there's two global categories of weight loss surgeries, at least the way we describe them. As surgeons, we call these restrictive or malabsorptive or both. I actually think there's a whole new category that needs to be highlighted and discussed, which is called a metabolic portion of the surgeries, and I'll try to point out why I think surgeries are metabolic as we go along. Real quickly here, normally when you eat, food that you've swallowed travels down this tube called the esophagus into the stomach. Once in the stomach, it gets processed lightly, and then it gets spit out into this first part of the intestine right here where the star is. Again, a very important landmark. It's called the duodenum or duodenum. It's the first part of the small intestine. It's critical because this is where that food hitting this part of the intestine sends a signal for this organ, the pancreas, to secrete or inject into the bowel critical digestive enzymes, as well as at that point we get signals for the liver and the gallbladder to empty some bile into the small intestine. It is so important for the bile and the digestive enzymes to interact with the food at this level, because without that mixing, actually, we would never break down that food into its into those building blocks, and we wouldn't be able to absorb the lipids, carbs, and proteins out of what we ate. So mixing happens early in the digestive system. Then we have from this point to basically just keep in mind the appendix as a landmark. The appendix is a landmark for the beginning of the colon. And so you have from star to the end point here, 16 to 20 feet of intestine before you reach the colon to absorb good, appropriate portions of calories as well as excess calories in addition to vitamins. Also, for your visual guidance in this slide and subsequent slides, I use this red bracket to indicate intestinal length. It's a rough estimate of the distance from that star to the appendix, and I hope you find that as a helpful tool, as you'll see on subsequent slides that it shrinks. So now that we understand normal function, let's talk about the first and most common weight loss surgery, the vertical sleeve gastrectomy, also known as the sleeve. The sleeve is done with a total of 5 incisions across the belly. let's don't get married to the notion of these incisions being right where they are in this picture. So incisions are placed where they need to be placed for surgery to be done safely and efficiently. Factors such as your own body habitus, size, makeup, for example, having a shorter abdomen and a longer chest, as well as the presence of previous surgical scars around the belly or coming up and down the middle here, will affect where these incisions are placed. But generally speaking, we're doing this with 4 small incisions across the belly, 1 under the rib cage. This one in particular, I'll go ahead and tell you, is usually not here in the middle. It's off to the right side. It can actually be anywhere from 1 centimeter to 2 centimeters or 2.5 centimeters long, because it's the site where once we're done cutting on the stomach, we remove that part of the stomach. It's also usually the most common source of pain after this surgery, again, because the most work is done through that incision. Now, this surgery takes 45 to 60 minutes to complete. We cut and remove 2/3 or 3/4 of the stomach forever. That's this part right here. And in doing so, we leave you with a rigid banana-shaped tube that acts as your new stomach. So this is the sleeve. And the reason this surgery works is, A, when we cut and remove this part of the stomach, we're removing the stretchiest part of the muscle fibers. We leave you with the less compliant, less stretchy muscle fibers here. So this rigid tube is, quote, restrictive, because food hits this thing and it won't stretch, it won't give, and you feel full even with a couple bites of food. So that's why it's called a restrictive surgery. Notice we don't do anything to alter the mixing point. That star stays right there. Food still travels down that stomach, gets lightly processed and spit out into here, where it mixes with those digestive enzymes from the pancreas and the bile from the liver. You still have 16 to 20 feet of intestine from here to here to get every little calorie out. I call it the most physiologic surgery for that reason. Now, why is this metabolic? I'm going to explain that on the next slide. But the really, truly remarkable hormonal component of this surgery, the metabolic part, I'm going to explain in a moment. But generally speaking, this is what it looks like when you're done. And again, we don't do anything to manipulate intestinal length. So what are the benefits of the sleeve? Let's talk about that. Basically, in addition to being the most commonly performed surgery, because it is, relatively speaking, the safest surgery and quickest surgery to perform, so especially if you're coming to the OR table with a lot of prior medical problems, a little bit older, and subtleties in how long the surgery takes actually is a big deal. Typically, this is for our heart failure patients, or older patients, then it can factor into what we're trying to accomplish, right? It was classically described as a strictly restrictive procedure. I think that was, to be honest, kind of an old school way of thinking. It's not that it's untrue, but it actually works in so many additional different ways that we've learned about in the last few years. Like I said, that rigid, non-compliant tubular stomach is now prone to getting fuller faster. Only a couple bites of food, especially that first few weeks, months, you'll notice like it takes such a small volume of food for you to feel full. But beyond that, it's metabolic too. So this to me is like kind of the magic of the sleeve, right? So that part of the stomach that was removed, it wasn't just some sack of potatoes or stretchy muscle fibers. So the stomach's job is not just to be a stretchy muscle. It's actually a complex organ. It's lined in the inner lining of the stomach with a variety of cells that make a variety of hormones, proteins, signaling molecules, and other things. So one of the key hormones that's made in the stomach is called ghrelin. So the majority of the cells in our body that make ghrelin, we believe, are housed in the stomach. There are some cells also in the first part of that small intestine, but the bulk of those cells are in the stomach. And we remove that cell volume with the stomach when we remove that part of the stomach. So ghrelin, you may remember from the first slideshow, is the key circulating hormone that controls our hunger in that key hunger and satiety control center in our brain. So by removing the cells that make that hormone and dropping those hormone levels way down right after surgery, we're effectively eliminating by a large degree, a large factor, your hunger stimulus before meals and in between meals. Through more complex biochemistry also, we're learning that ghrelin, potentially other hormones too, by removing ghrelin, we're actually resetting that what I call the metabolic rate thermostat in the brain too. Remember, normally when you were trying to diet and metabolic adaptation kicked in, we had mechanisms that drove up our ghrelin levels to make us more hungry. We also had something causing our metabolic rate to drop down so that we couldn't lose weight even though we were trying as hard as we could. So, right after surgery, and this is kind of the magic of the surgery, when you're done and you're getting off the OR table for the first time in maybe years, if not decades, we have very physically gone in and dialed that metabolic rate thermostat up so your metabolism is way higher than it's ever been. Maybe not right after you get off the OR table, but we think based on experiments by about month 2 after surgery to about month 11, 10, 11 after surgery, that metabolic rate is set higher than it's been and it stays there. That's when I tend to say to get the most bang for your buck, you need to be exercising. Because again, you want to take advantage of that high metabolism while you have it. Unfortunately, the body will try to adapt and figure out ways to bring that metabolism back down. But the true reason why in the first year after weight loss surgery, the sleeve can be at times as effective as what would appear to be a more drastic surgery like the bypass, I think it's because of this metabolic component. And for some people, that's all you need. You just need that first year of tremendous restriction and a high metabolism to reset yourself. Get back down to that healthy weight, reform new habits, reprocess, rethink the way you look at food, smell food, prepare your food and enjoy your food, and hopefully you create a lifetime of new habits, and then you can use that tool, the sleeve, and all these weight loss surgeries, they're just tools to maintain your weight loss. So that's the metabolic reason I think that this is such a great surgery. But again, those metabolic effects don't last forever. We do know that the metabolism will come back towards your baseline levels. It does tend to live at a slightly higher level than a true baseline, but it's not going to be way high like it was for those first few months after surgery. 75% of patients have a significant improvement in medical comorbidities, other medical problems that you may be seeking treatment for, high blood pressure, high cholesterol, sleep apnea, you name it, diabetes as well. 60 to 80% excess body weight loss is what you can expect with a sleeve gastrectomy. What's excess body weight? That is your current weight minus your ideal body weight, which you can use an online calculator to figure out. That's the weight we're trying to work on, and you can expect anywhere from 60 to 80% of that number to come off after surgery. Some people exceed the 80%. It tends to be my younger, more active patients. Some people don't even get 60%, right? This is a wide range because this patient population that we followed includes a wide variety of people. So that includes different ages and different levels of, again, these comorbid diseases. Sometimes we have someone getting a weight loss surgery just to qualify for a heart transplant. Oh my God, that patient's not going to be able to benefit from extra effort-related things like exercise, right? So their weight loss is completely reliant on maybe this metabolic part and a little bit of the diet. So you got to realize when we say 60 to 80%, you're going to fall somewhere in that range. Hopefully, I've seen people be disappointed by the results. They didn't even fall in this range when, I'm talking to them, it seems like they should have. So then brings to question, are there huge genetic components to this that we don't fully understand yet? Or is the patient being totally honest with me or themselves too in terms of what they've done to retailer their habits, right? Again, all these surgeries are just tools. If you don't use them properly, you're not going to get the results you want. But sometimes there's factors other than the things that we can control that are at play. Generally speaking, this requires a one-night stay in the hospital to make sure that the initial part of your recovery is going well. I'll tell you, if you're relatively younger, relatively lower BMI. If you don't have a lot of medical conditions, you have a good support system at home. Some places we are doing these things outpatient surgery, so you go home the same day. Maybe something like that will be available soon in the Atlanta area. But as of now, we want our patients to stay a night. And, you know, that's probably for your benefit, right? To have an extra set of eyes and a hand to help you get acquainted with your surgery pains, your incision, and just to make sure you're safe with like an extra, you know, an extra set of labs in the morning, and check some boxes before we send you home. All right, moving on. Let's look at the potential complications or side effects after sleeve. I want to point out that these are this is a small list compared to the comprehensive list of potential complications. It basically, to me, these are the highlight buzzwords I want you to keep in mind because they're more technically related to, you know, the way that the procedure's been described to you so far, and things related to the actual surgery of cutting on the stomach. But needless to say, when you sign a consent form for surgery, it's going to have a whole bunch of other stuff listed. The biggest thing I want to drive home here, this slide is not here to scare you or deter you. It's to be frankly honest about things. There's no such thing as a surgery without any complications. And what you need to know before I show you any stats or any named complication is that weight loss surgery, although historically it may have had, for some legitimate reasons, a bad rap, listen, things have gotten way better. Technology is better. Our ability to do these surgeries safely is better. Our education of patients and preoperative testing is way better. Our ability to detect complications early after surgery with the advent of better CT scanners and other techniques and different modalities to treat potential complications, the number of people, first of all, having complications and then, you know, having the worst outcome from any of these, which would be dying, has gone way, way down. And so weight loss surgery carries overall the same risk of complications and deaths as any other common surgery that's offered in the general surgery world, and even outside of general surgery in other subspecialties. And so keep that in mind as we review these things. We wouldn't be doing these surgeries and offering them without ample education, preoperative workup and optimizing, and of course without the number being overall very low and low risk for complications. So just keep that in mind. The first potential complication I want to talk about is a leak. Anytime we cut the stomach or cut small intestine and divide and reconnect things, there's a chance that where it was supposed to connect and heal, that there's a leak. What could leak out? Bacteria, bile, acid, saliva. These kind of things could cause an infection in your belly, a true what we call intra-abdominal sepsis. That happens, fortunately, 0.5 to 1% of all the cases being done. And people who go on to have a worse complication from a leak, that's even smaller. So generally, if there is a leak, it's going to present with an abnormally severe pain and a variety of symptoms that we would cover for you to go home after surgery and monitor for. But if you had those symptoms, generally we direct you to the ER. We're going to diagnose it, and then now we have a variety of ways to treat and kind of nurse you through that. So again, a leak is when there's a failure to heal of a small intestine or stomach, particularly where we cut the stomach and remove that part. If that doesn't heal, that can cause a leak. The other technical, just surgery related complication that's a potential issue with a sleeve is called a stricture. A stricture is a narrowing of a tube. So where this typically happens is about halfway down or 2/3 of the way down that tubular stomach, and that could cause you to have discomfort while you're eating or swallowing. It could cause nausea or vomiting, cause reflux issues and other symptoms. Typically, I think, you know, I honestly think 5% is a relatively high estimate of how often this happens. I can tell you at Beltland Health, I think that number is far lower. And a lot of the reported data about strictures was earlier on, before we figured out how to from a technique standpoint, calibrate the size of that tube more reproducibly. I also think it has something to do with surgeons doing this that haven't had proper comprehensive bariatric surgery training. Let's face it, somewhere out there, there's surgeons that have watched their coworker or colleague do 20 of these, and now they're certified to do bariatric surgery. So when we have issues with technique, sometimes that can cause a narrowing when you heal, but sometimes we do it perfectly, and the body just, when it goes and lays in that healing protein or scar tissue, it can narrow it. So sometimes it can be bad luck, but that's called a stricture. Reflux, I tend to call this a side effect of the sleeve more than a complication. It happens 20 to 30% of the time. We think it has to do with this new sleeve tubular stomach being a high pressure system compared to that floppy bag-like stomach. We also think it has to do with if you have an undiagnosed hiatal hernia that's not repaired at the time of surgery, that can cause your reflux to go up. The bottom line is I usually describe reflux, also known as heartburn or gastro-esophageal reflux disease, once you've had symptoms severe enough for long enough, as happening in the following way. So if you come to see me for surgery and we pick a sleeve and you have some degree of reflux, a third of the time your reflux can get cured actually. Why? Because a big component of your heartburn issues is related to having central obesity, extra weight on your stomach and pressure, and also you having generally an unhealthy diet. So when we factor in that we're going to re-educate you on how to eat properly, how to eat healthy, generally the way we teach you to eat is also how we teach people to eat to manage their reflux, and we combine that with a rapid weight loss with the weight loss surgery, a third of the time or even more your reflux actually gets cured, even with a sleeve, which could be high pressure. About a third of the time your reflux, if you came to the OR table with a little reflux issue, can stay about the same, but apparently 20 to 30% of the time it can get worse for factors that we don't fully understand. I will do, in the last slide, I'm going to explain some other components related to reflux and how we want to address them, specifically a hiatal hernia. But keep this in mind about going the route of a sleeve. This is a good time for me to talk about our selection of the sleeve. So who is the sleeve generally a good idea for? I think if you don't have a super high BMI, specifically 50 or higher, we can talk about a sleeve. And as long as you don't come to the clinic with moderate to severe gastro-esophageal reflux disease or reflux or heartburn, I think a sleeve is fine. If you have horrible heartburn already, have been on medications for a long time, have failed medications even, I think we really need to talk about something else like the gastric bypass. So reflux is something that if you already have it, it's pretty bad and it's taken over your life, we want to stay away from the sleeve. Otherwise, I tend to say a sleeve is not a terrible option for anyone. I think it's a great surgery. You can get good results for it. Can you get optimal, the most weight loss with the sleeve compared to something like the duodenal switch or the SADI surgery, which we'll talk about later? No. So when you have a much higher BMI, unless you're really set on the sleeve, I may talk to you about offering something that could offer some more weight loss and better resolution of your disease. But even in those situations, some people say like, hey, a sleeve's still a great first chance. See how far you could take it. Maybe you can break, not to say that you'll be that one exception to the rule, but certainly not everyone fits into that 60 to 80%. I've been surprised to see that even with a sleeve, patients have lost 90% of their excess body weight. But we're really going to tailor that discussion and that decision to you when we see you in the office. So keep that in mind. Malnutrition, this is something that goes on every slide with every weight loss surgery from now on. With the sleeve, again, because it's the most physiologic surgery, I worry the least about malnutrition with the sleeve, but in that first year when you're struggling to get in enough calories, it is possible to be overweight and be malnourished, believe it or not. The best way to avoid a malnutrition issue is to take at least 1 to 2 vitamins a day for the rest of your life with the sleeve. It can be forgiving if you went to Mexico for a week or two, didn't carry your vitamins with you. But the best thing to do is know that once you're going down the route of needing and maintaining your weight loss surgery, you're going to want to take the vitamins. You're going to want to follow up with us periodically and check those vitamin levels, or your primary care doctor can do that. So let's don't run into an unnecessary problem such as malnutrition, especially in an era when we have, golly, like 100 companies that make vitamins, and they're actually pretty, nicely priced. So there's really no excuse to running into a malnutrition after a sleeve. There are multiple other potential complications with a sleeve or general anesthesia in general. This is the part of the slideshow where I say I could sound like the end of a medication commercial. Call your doctor if da 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 da, and you're like, why would I ever do that? Well, like I said, there's no such thing in medicine as doing something that has no potential side effects or complications, right? The point is, the risk of these things happening is so low compared to the benefit of getting the surgery done, getting to a healthy weight, curing yourself of all these diseases, and really setting yourself up for literally a better and longer life, right? So the probability is in your favor that you're going to have a success and positively impact your life, and that's why important to be educated on these things, but mainly to understand that we've gotten these risk profiles pretty low with these surgeries at this point. So always weigh the risks and the benefits. I love weight loss surgery because 99% of the time the benefit outweighs the risk. So with that, let's talk about a separate but related issue before we wrap up here. I want to talk to you about a hiatal hernia, and the reason I want to talk to you about hiatal hernias and a little bit about reflux is this: 21% of all bariatric patients have a hiatal hernia. Whether you have symptoms of reflux, that's heartburn, chest pain after a meal, particularly like a spicy meal or a meal with tomato sauce or something like that, those are the common causes. And up to 20% of patients have true GERD, gastro-esophageal reflux disease. To qualify for GERD, you have to have symptoms like I described, with or without regurgitation. And once you have it enough days a week and severe enough symptoms, you have, a true diagnosis of GERD. So up to 27% of our patients with an unhealthy weight will have associated GERD. I actually think the number is higher if you factor in something called asymptomatic GERD, or people who say, I don't really experience that, or I'm not bothered by it, but come to find out, you do testing on them and they have horrible reflux, or God forbid, but you run a camera down and you actually see damage to the esophagus from all that kind of asymptomatic reflux that's going on. So once you have an unhealthy weight, the bottom line is unhealthy weight is associated with a bunch of other medical problems: diabetes, high blood pressure, cardiovascular disease, hyperlipidemia or cholesterol issues, fatty liver disease. Add to that list GERD too. It's another thing that we hope to solve with your weight loss surgery, but as I pointed out with the sleeve, 20 to 30% can get worsening GERD if you already have it, and we're seeing up to that rate of people develop a new heartburn even if they truly didn't have it. So that's why I think it's worth talking about. And if a hiatal hernia is present, we want to repair that, especially with the sleeve. Now, what is a hiatal hernia? I've indicated here in the picture that this is the esophagus that carries that food down to your stomach. Where your esophagus connects to the stomach should be in the true abdomen. The true abdomen is the area under your diaphragm. So the diaphragm is a muscle that helps you breathe. We can think of it as the wall that separates our chest from our stomach, right? So ideally, we have something called the distal esophageal sphincter. Think of it as a kind of trap door that allows the food you swallowed to enter the stomach but not leave. So it should close behind the food you ate, such that acid and even food that's even partially processed has no way of going back up into the chest. This sphincter on its own needs to have a certain strength and quality that we think is diminished over the years due to environmental factors. What are you eating, how much you're eating, and things like that. But there are reasons that the mechanism of this starts to fail over the years that we don't fully understand too. Beyond that, we need to realize that this sphincter doesn't work by itself. There's a team of things going on down here to help it work properly. Number one, the position of the sphincter being in the belly and not in the chest means it can borrow some of the positive pressure from that abdominal environment to help it close properly. Once the sphincter finds itself in the chest, where we typically have negative pressure, low pressure system, it can negatively influence the function of that sphincter. The other thing is where the diaphragm has a hole in it. We're born with a hole in our diaphragm, so exactly this can happen. The esophagus can travel from the chest to the belly. When that hole gets dilated, and I'm going to try to show you, look at the distance from this side to this side compared to when you have a hiatal hernia. That length over here is shown to be doubled or tripled in size. So a dilation of that hole, the hiatus, is called a hiatal hernia. When it gets big enough, the top part of the stomach, which should be in the belly, starts to migrate into the chest along with that sphincter. And guess what? This can cause you to have regurgitation and reflux or heartburn, okay? Now, why does the sleeve tend to make this work? Potentially, if you already have a laxity here, and we are going to cut the stomach from literally about here down along the stomach to the end, we're making it a tube that's high pressure and can more easily fit into this hernia. Well, that could make your reflux and heartburn worse. So preoperatively, at least at Beltline, we do a survey screening to see how bad any reflux you have is. We then do x-rays to see if you have any what degree of reflux you might have, or do you have a hiatal hernia. Sometimes we're going to recommend an EGD as well. An EGD is an endoscopy to look down here with a camera and make sure that this part of the esophagus is not injured from all that acid beating up on it for over the years. So at the time of sleeve, we're going to want to put stitches in this to narrow it back down to this size and hopefully mitigate that risk of you getting worsening heartburn or heartburn issues. So that's a hiatal hernia, and I hope you found this presentation overall to be helpful in understanding one of the first surgical options, the gastric sleeve, how it works, some of the risks and benefits, and stay tuned. I hope to do a segment on the gastric bypass next, and then the duodenal switch, and the newest version of the duodenal switch called the SADI as well, and in a similar fashion talk about how they work and the risks and benefits of each. So stay tuned. Thanks for tuning into our presentations here at Beltline Health, and I look forward to chatting with you again. Talk to you soon.